Okay, good afternoon, everyone. Let's go ahead and get started. We have two lectures today, no exam tomorrow, two lectures today on fibrinolysis, and I'm going to be talking about platelets. Everybody should have gotten their current grade status. I emailed them to you last night. And then I'm going to be talking about the grades and the upcoming exams and quizzes. Okay, so fibrinolysis, relatively short lecture. 24 slides, and platelets a little bit more complicated, maybe about 40 slides. After that, I'm going to do a little review on the two quizzes, and also I'm going to go over after the lectures the coagulation cascade. The coagulation cascade is, I usually do that on the board. Unfortunately, I'm not in the classroom, so hopefully what I'll be giving to you will help you be able to memorize the coagulation cascade. So there's major things that you need to memorize. One of them is this coagulation cascade. The second one is the fibrinolytic pathway, and that's going to be in this lecture right here. And the third one is a large table, and I'll show that to you when I go over the coagulation cascade. So those three major things are pathways and tables that you need to memorize. I'll also be sending you, since it's a holiday next Thursday, and then when you come back, you'll be getting an exam on the Thursday. But I'll give you a review. I'll send you a reviewer, hopefully before this weekend, and you can. It's up to you to review it over the Thanksgiving week, the holiday. But when Wednesday on our last meeting, that'll be our very last meeting, I'll go over a review over the over your exam, and then for your final exam as well. Okay, so let's go ahead and get started on fibrinolysis. So the fibrinolysis is the other half of hemostasis. The first one is coagulation. You need to know your body needs to coagulate and clot so that you don't bleed profusely and all over the place. So you want the clotting process to not last forever. That's why you need to have fibrinolysis. You can't have too many clots going on. Also, too, when you have DIC, DIC is the spontaneous clotting in your circulatory system. And I'm going to talk about that's called DIC, as I mentioned before, the spontaneous clotting. That's a critical value. You don't want to spontaneously clot. So there are things that they give you so that you can treat it, because DIC is a critical value, like I said. Okay, fibrinolysis. Let's see here. Okay, fibrinolysis prevents clots from growing. Like I said, we want clots to stop growing, because otherwise, if they keep on going, you're going to be just one giant walking clot. We want to remove unwanted fibrin deposits, and it's done enzymatically. And the enzyme that we're interested in fibrinolysis, the main enzyme, make sure you need to know this. The main enzyme in fibrinolysis is plasmid. And plasmid comes from plasminogen. That's the main enzyme. Okay, so when all this chopping goes up, the fragments of the fibrin clots, you have all these fragments and all this junk going around. Macrophages are still come into play. They remove the fragments from circulation, because the plasma is going to chop it up, chop, and all this fibrin deposits are going to be circulating around in your blood. Well, you don't want too many of those fragments of fibrin. That's why macrophages still play a major role in the cleanup of these fibrin deposits. Okay. Removal of fragments reestablishes and inserts blood flow in the blood vessels. Okay, so now the healing process has stopped. You need to get blood flow going again. That's what fibrinolysis does, because what you're doing is you're cleaning up the fibrin. It also helps keep open the lumen of an injured blood vessel. It's part of the cleaning process. And after the wound has healed, the fibrin is dissolved via fibrinolysis. So the fibrinolysis cleans up the wound after it's healed. Again, you got your excess fibrin. The fibrinolytic enzyme plasmid will go ahead and clean it up. And the fragments will be taken care of macrophages. Macrophages, like I said, they go around. They're the garbage trucks, remember? They go around circulating in your blood, and they pick up the fibrin fragments. Okay, hemostasis. I went over this last time, and now I'm going to get into more technical terms like primary hemostasis and secondary hemostasis. So when you get an injury, what will happen is your blood vessels will contract. Your body is responding to that injury, and the contraction of your blood vessels is a smart thing, because if you don't want to dilate your blood vessels or keep it open. You want to constrict the blood vessels so that so that you can control the bleeding. Okay. At the same time, during the injury, immediately after the injury, endothelial cells in your skin will release substances, and that's actually what triggers the things that happen. Like, for example, one of the first components that arrive at the site of injury are the platelets. Okay, the platelets are thrombocytes. They get activated, they become sticky, they change shape, and I'll go over that later. So they physically change due to a chemical response from the endothelial cells when you get a cut, okay, when you get an injury. So these thrombocytes or platelets will start to aggregate and close the wound. This is called the white thrombus. That's what I discussed last time. But the aggregation of platelets on top of a wound is called the white thrombus. Make sure you know that. That's the first part. The platelet aggregation to stop the bleeding, it's called the white thrombus. In secondary hemostasis, just because you have the platelets congregated over there and it's helping to stop the bleeding, the platelets alone will not stop the bleeding completely. It'll slow down, but unless the platelets are intact or held in place, it's not going to help. So what happens is, this is where the clotting factors come into play. If you think about the coagulation cascade, and we're going to go over the coagulation cascade, remember the end product of the coagulation cascade is a fibrin clot. The purpose of the coagulation cascade is to form fibrin, okay? Fibrin. The end product of fibrinolysis is to chop up fibrin, is to dissolve fibrin. So make sure you know what the end products of these cascades are. I mean, it's one thing to memorize them, but if you don't know the purpose of each of the cascades, then you probably are lacking in some part of understanding. The coagulation cascade needs all the factors, all the components in order to form that fibrin clot. If something's missing, like for example, when you draw an EDTA tube, or if you draw sodium citrate tube or lithium heparin, you always get whole blood. Whole blood meaning that it hasn't clotted. But what you've done was you've taken out a component of the coagulation cascade. So the key point is, if you take out a component of the coagulation cascade, in the case of your phlebotomy tubes, what you're taking out is calcium. Okay, you take out calcium, the anticoagulant will take out calcium. If you take out calcium from the coagulation cascade, you will not clot, and that's why you have whole blood. You don't form a solid blood clot. Okay, so the opposite of the coagulation cascade is fibrinolysis. So make sure that you know that the end product of the fibrinolysis pathway is to chop up fibrin. So what happens when you have an injury? Your coagulation factors, okay, so your platelets have arrived, right? Your platelets have arrived at the site of injury. The factors, the coagulation factor, like the 2, 7, 9, 5, 10, 12, all of these factors are circulating around in your blood, and they're just circulating around, not doing anything. It's not until they become activated, they turn into 12A or 11A and 9A, etc., 5 and 5A. And it's not until that they get activated, they turn that they will arrive at the site of the injury. So when these activated factors arrive at the site of injury, they all work together with the calcium, because nothing's been taken out, to form fibrin. So what happens is, the platelets need help. So they get their help from the fibrin that has been created from the factors circulating in your blood. So the factors that circulating in your blood work together to form coagulation cascades, and fibrin is deposited. The fibrin that is forms a meshwork on top of the platelets is called the red thrombus. And this red thrombus forms and permanently closes the damaged blood vessels. So you start off with the white thrombus, which is the platelets. And then when the coagulation factors become activated, they will go to the site of injury and form a meshwork, a net, so to speak, on top of the platelet plug. Okay, it's called a platelet plug that's there first. So what happens, that's what actually forms a scab. And I know you've all seen scabs. You all had wounds on your arms or whatever, and then you form a scab. Well, that scab is basically a collection of platelets and fibrin, and it gets really hard. So that's your clot. And it's up to your body not to continuously form clot and fibrin. Like I said, you don't want to form clots forever. That's why you have the fibrinolytic pathway. So your wound has healed. It's formed the red thrombus. And after the thrombus forms, the contraction of the vessels in the thrombus now starts to relax. Remember, you have an injury, your body's going to react. It's going to contract the blood vessels because your body does not want you to be bleeding all over the place. That's a response that your body is making in response to an injury. So after the thrombus forms, then the contraction will reverse itself and will relax, okay? So here's the fibrinolytic pathway, fibrinolysis. The main enzyme here is plasmin. The main enzyme of plasmin is plasmin, and that's responsible for chopping up fibrin. Chop, 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 and to form the fibrin degradation products. You need to memorize this pathway. And when what'll happen is on your test, you'll basically be given a blank sheet of paper, but with a word bank, and you're going to need to outline the pathway: plasminogen going to plasmin, going to the scissors, fibrin going to fibrin degradation products. These factors here, or components here, are either activators or inhibitors. So the main reaction of fibrinolysis is basically plasminogen going to plasmin, going to chop up the fibrin. This is fibrinolysis right here, okay? These three things. These components here will either activate it or inhibit it. So the arrows that are in blue, are activators. So for example, TPA, or tissue plasminogen activator, will activate plasmin. So this will facilitate the fibrinolysis to take place. Urokinase, it's blue, so it activates fibrinolysis. There's also another enzyme, streptokinase. So here it's urokinase, streptokinase. These factors here, 11A, 12A, and kallikrein, these are activators, okay? These three components here will activate the fibrinolytic pathway, okay? So meaning that in the presence of these enzymes or proteins, the clot will dissolve, okay? Now, we don't want fibrinolysis to take place forever. Just like the coagulation cascade, you don't want to form clots forever. It has to be in control. So here we have, this is tissue plasminogen activator. And so here, this inhibitor is called Plasminogen Activator Inhibitor 1 and 2. So it's Plasminogen Activator, this one, inhibitor. And so this inhibitor, Plasminogen Activator Inhibitor, will act on the plasminogen activator. It'll inhibit it. And it'll also inhibit urokinase, streptokinase. So here we have tissue plasminogen activator to activate the fibrinolysis, and this will inhibit it. Plasminogen activator inhibitor, okay, acting on the TPA, tissue plasminogen activator, and also will inhibit urokinase, streptokinase, because those two enzymes, urokinase, streptokinase, are also activators. So Plasminogen Activator inhibitor will inhibit those. Two other inhibitors that you need to know are the two alpha 2s. So that'll be easy to remember. So alpha 2 antiplasmin, the name itself tells you that it's an antiplasmin, okay? Alpha 2 antiplasmin and alpha 2 macroglobulin. So just remember, the two alpha 2s are inhibitors. The two alpha 2s are inhibitors, meaning that it will inhibit the action of plasmin. So in the presence of these two, plasmin will not chop the fibrin, okay? It'll stop fibrinolysis. Plasminogen activator inhibitor will inhibit tissue plasminogen activator, which is an activator, and it'll inhibit urokinase. So those are the main components of fibrinolysis. Down here, you have thrombin activatable fibrinolysis inhibitor. So the name itself also has fibrinolysis inhibitor in it. So it's going to act on the scissors here. And thrombin will activate, well, it doesn't necessarily activate, but thrombin will turn into fibrin, and thrombin will turn into thrombin activatable fibrinolysis inhibitors. So make sure when you do the pathway that you have thrombin here. Thrombin goes to fibrin, and thrombin goes to thrombin activatable fibrinolysis inhibitor. Okay, so just to recap, the activators are TPA, tissue plasminogen activator. Urokinase streptokinase will activate it. The factors here will activate it, 11A, 12A, and kallikrein. Those will activate it. The inhibitors are plasminogen activator inhibitor acting on this one. So that makes sense, plasminogen activator inhibitor. And that will act on this one, and then it'll act on this one. And then the two alpha 2s. The two alpha 2s are inhibitors. So when you're going to be doing the fibrinolytic pathway, you're going to be given a word bank. So to help you out, the word bank, all you have to do is to put everything in place. Okay. So I would recommend trying to memorize you got your core reaction here. Whoops. Your core reaction there, which is plasminogen. Remember, plasminogen, the name itself implies it's a precursor of plasminogen, and then plasmin is your main enzyme. So plasminogen goes to plasmin, just like fibrinogen goes to fibrin, and prothrombin goes to thrombin, just like that. So here's a precursor going to your enzyme, and it's going to chop the fibrin, okay? And then you're forming fibrin degradation products. And I'm going to go into what happens to the fibrin degradation products later on in this lecture. So I would recommend getting a blank piece of paper and writing the core reaction down here, and then starting with these components. See if you can try to do it. Try to, by next Wednesday, when I see you again on the last meeting, see if you can reproduce this fibrinolytic pathway. Okay, that's going to be, like I said, it's going to be like a blank sheet of paper with a word bank. You need to put everything together in its right order. All right, plasmid inhibitors. So basically, I'm going from what's illustrated here to the.
I have a question for you.
Go ahead, Rudy.
Are you going to have us meet next Wednesday also?
No. The next Wednesday after. Next Wednesday, you got off. So because it's Thanksgiving week next week.
Okay, I'm sorry, I didn't hear it correctly. Thank you.
Well, that's okay. So the next Wednesday that I see you, not next Wednesday when I see you, the next Wednesday that I see you will probably is going to be the Wednesday after Thanksgiving. I think that's December 2. So the plasmid inhibitors, like I said, are the alpha 2s. Make sure you know that the two alpha 2s are inhibitors. The alpha 2 antiplasmin is a rapid inhibitor, and the alpha 2 macroglobulin is a slow inhibitor. Make sure you know the difference between the two. But the two alpha 2s are inhibitors. You got the rapid and the slow. Macroglobulin is slow. Just think if you're way too big, elephants are slow, and the plasmin, since it's specific for plasmin, it's going to inhibit rapidly. Okay. So plasmin inhibits rapidly. Large objects are slow. Macro. Okay, macro for large. Plasminogen is the precursor to plasmin. It's made in the liver, has a half-life of 2 days, and it's circulating in the blood until it's activated. All these things are circulating in your blood until it's activated. And what activates these proteins or factors is injury. So the release of those endothelial substances, those endothelial fluids, when you get a cut, is tells your body that you have a cut, and it's going to deploy all these platelets. The platelets will arrive first, and then after the platelets will arrive, then the activated factors will arrive. The activated factors will form fibrin. The activated factors will go through the coagulation cascade and form the fibrin. You get the fibrin meshwork, and that's when you get your white thrombus. Is it the white thrombus? Right, red thrombus. First it's white, then it's red. First it's white, and then it's red, okay? So plasmin is formed from plasminogen and acts on fibrin to produce lysis of the clot. As I said, plasminogen is activated by plasmin. Plasminogen is activated to plasmin by TPA. TPA is actually a drug that they give in the ER. If a patient has DIC, remember, DIC is disseminated intravascular coagulation. That's when you're spontaneously clotting in your circulatory system. You don't want that. It's a critical value, because if it continues, if you continue to have spontaneous clotting, forming fibrin for no reason, then you're going to die, okay? Because, you know, your blood vessels will occlude, you're going to get strokes, you're going to get heart attacks, because all of this fibrin is now floating around and clogging up your blood vessels. Well, in the ER, they have TPA in a bottle, okay? TPA is tissue plasminogen activator. So what it does, it will activate plasminogen. If you activate plasminogen, plasminogen will go to plasmin, and plasmin will chop up that fibrin. So TPA will turn on. It's the ignition key. It'll turn on fibrinolysis. Okay. Tissue plasminogen activator. TPA. So that's what they give in the emergency room, especially if they suspect that you're going into DIC. And there, like I mentioned in the last lecture, there are a lot of situations where you can go into DIC: pregnancy, burns, electrocution, okay, bacterial infection, acute leukemia. Remember acute leukemia M3 with the promyelocytes? That can set you off and you can go into DIC. So there's a lot of things that you that can put you in DIC that you need to be aware of. But one of the first things that the doctors will do if the DIC is suspected is you need to get that plasminogen activated to go into plasmin. And what that thing is TPA, tissue plasminogen activator. That will activate fibrinolysis. Plasminogen exists in two phases: the soluble phase, which circulates freely in the plasma, and the gel phase, which plasminogen is actually absorbed to fibrinogen or fibrin. Okay. And the soluble phase. First, the soluble phase, plasminogen is activated to plasmin spontaneously. So you have plasminogen floating around in your circulatory system. Sometimes plasminogen, those small amounts of plasminogen, will just want to be converted to plasmin. Okay, so plasminogen going to plasmin will take place. If a lot of it happens, that's not good. Otherwise, you're going to have bleeding tendencies. Okay, but just a small amount of plasminogen will be converted to plasmin. On the other hand, to keep that process in check, is that small amounts of antiplasmins present in the plasma will continue to neutralize the plasmin. So you also have antiplasmins circulating in your blood system to keep that plasmin that's formed from the spontaneous activation of plasminogen. So you still have a little balance that's take place. It seems like it's a little sneaky because plasminogen is going to convert to plasmin, right? So you think that that plasmin is going to is going to run amok and take over? Well, you got antiplasmins also available that's circulating around in your blood. Well, these antiplasmins will counteract the plasmins that are developed, so you don't have fibrinolysis running amok and just taking over. Okay, so you got continual neutralization of plasmin. In the gel phase, when plasminogen is in the gel phase, activators diffuse into the clot, converting plasminogen to plasma. Okay, so the activators will diffuse into the clot. Remember, the fibrin clot is what is being attacked. Diffuse into the clot and converting plasminogen to plasma. Excuse me. Since there are no antiplasmins within the clot, okay, then plasmin is free to break down the fibrin, and any fibrinogen present. Okay, so there are no antiplasmins within the clot. So plasmin has combined with the fibrin. So to counteract that, plasmin is an antiplasmin, but since the plasmin is not available to be counteracted by antiplasmin because it's within the clot, then the clot can break down. Okay, because if the plasmin was available, then antiplasmins will act on the plasmin, and you won't get clot lysis. So since the plasmin is already within the clot and it's not able to be acted on by any antiplasmin, then the plasmin is free to break down the fibrin and any fibrinogen product. You guys understand that? I hope you weren't confused. So what happens is the plasmin will attach to fibrin. Okay, if plasmin was free, it's going to be attacked by antiplasmin. Okay, however, once plasmin attaches to fibrin, because antiplasmin will leave the plasmin alone because the plasmin is already attached to fibrin. So the antiplasmin will not bother the plasmin, and the plasmin can go ahead and proceed and dissolve the clot. If the plasmin was free, then antiplasmins will act on the plasmin, and then the clot will remain intact. There won't be any clot lysis. Okay, so the fact that the plasmin is already bound to fibrin, that protects the plasmin from being destroyed. If it was free, it would be destroyed. Okay, just want to make sure you understood that. I think I said that about 3 different ways. If you have trouble, just let me know. But the key thing is plasmin needs to be bound to fibrin. I think later on in the lecture, I'll bring it up again. So Plasminogen Activators, again, TPA, Tissue Plasminogen Activator, the factors, 12A, 11A, and kallikrein. These are the 3 factors that will activate plasminogen, and the urokinase, streptokinase. These 3, TPA, the factors, and these enzymes will activate fibrinolysis. Okay, so the breakdown of these into TPA, the factors, and the enzymes, urokinase, streptokinase, will activate plasminogen to plasmin. It will activate fibrinolysis. So TPA, like I mentioned, that's what they have in the ER, just in case a patient comes in with DIC. TPA and tissue thromboplasmin is an initiator. Tissue thromboplasmin is an initiator of the intrinsic pathway. Remember, extrinsic pathway is factor 7. These are released with endothelial damage. So remember, once you have an injury, you have endothelial substances, fluids, leaking out into your circulatory system. So endothelial damage is actually the start of this. So TPA and tissue thromboplasmin are released with endothelial damage. TPA binds to fibrin. I mentioned that earlier. Plasmin will bind to fibrin. So TPA will bind to fibrin as it activates fibrin-bound plasminogen. TPA will not bind to will not bind to circulating plasminogen. It's similar to what I mentioned earlier with plasmin binding to fibrin. But if plasminogen is bound to fibrin, then the TPA will not take place. Therefore, efficient dissolving of the clot without causing systemic fibrinolysis. So TPA will not bind to circulating plasminogen, therefore is efficient in dissolving a clot without causing systemic fibrinolysis. You don't want systemic fibrinolysis, okay? Otherwise, what will happen is that you'll bleed to death. Again, the key thing for fibrinolysis is fibrin-bound plasminogen. If fibrin is bound, if plasminogen is bound to fibrin, then fibrinolysis can take place. Okay. Okay, so plasmin, the main enzyme, has the ability to proteolytically degrade the fibrin clots and native fibrinogen. So what happens is so when you chop up fibrin, you're going to be forming fibrin degradation products. When you chop up fibrin, what happens to the fibrin? Well, you form what's called fibrin degradation products. And the first degradation product is the X fragment. Okay, the X fragment. The X fragment will undergo further degradation to form Y and D fragments. And the Y and D fragments are unclottable. And the Y fragment is then further digested to form D and E fragment. Okay, so here's what it looks like. X fragment will degrade to form Y, will be broken down to form Y and D fragments. Okay, and the Y fragment will further be degraded to form the D and E fragment. Okay, so these are the fibrin degradation, how they're formed. So X fragment will form Y and D, and the Y fragment will form D and E. I don't have this on your original lecture, so I can send you this PowerPoint, resend it to you so you have it. So, and then the cleavage of the X-linked fibrin will be degraded, and that's what forms the D dimer. Okay, the proteolytic cleavage of the cross-linked fibrin results in other intermediate degradation products, and this proteolytic product is called D dimer. It's called D dimer. Okay, so you got your D and E fragments formed from your Y, and your Y and D fragments formed from your X fragment. Okay, plasmid inhibitors. So these things will stop fibrinolysis from taking place. So plasmin formation takes place mainly in the area of fibrin deposition. So wherever fibrin is located, plasmin is going to shoot over there. So if plasmin is unchecked by the presence of the inhibitors, then you will get circulating fibrinogen being digested, and the blood will now be rendered unclottable. You don't want that. You need to have hemostasis. Your blood needs to be clottable. Okay, you need to have hemostasis, the balance between coagulation and fibrinolysis. The primary plasmin inhibitor is the alpha-2 plasmin inhibitor. Remember, the two alphas are plasmin inhibitors, and the one that's the fastest is the alpha-2 plasmin inhibitor. The alpha-2 macroglobulin is a plasmin inhibitor, but it's slower. The alpha-2 plasmin inhibitor irreversibly binds to plasmin unless it's bound to fibrin. So that's the key thing. If the plasmin is bound to fibrin, then the inhibitor will leave it alone. The plasmin alpha-2 plasmin inhibitor complex. Okay, so it has found free plasmin. The inhibitor has found free plasmin that's not bound to fibrin. It's thought to be the activator of the fibrinolytic system. So the alpha-2 plasmin inhibitor complex bound to plasmin will activate the fibrinolytic system.
Professor, real quick, can you go over that again? Just the difference between plasmin when it's bound to fibrin and when it's bound to the alpha-2?
Okay, so alpha-2, I know we have to read it about 2 or 3 times. Alpha-2 plasmin inhibitor will bind to plasmin. Okay, it's an inhibitor. Remember, the two alphas will inhibit plasmin, okay? Unless it's bound to fibrin. If it's bound to fibrin, then it's going to take place. But the alpha-2 plasmin inhibitor is going to inhibit fibrinolysis. It's going to inhibit plasmin from chopping up the fibrin. Okay, but if plasmin is already bound to fibrin, then it's going to chop up the fibrin. Okay, so plasmin, alpha-2 plasmin inhibitor will bind to plasmin and inhibit plasmin. So what that states is the clot will remain intact, correct? You see that? The plasmin inhibitor will stop the plasmin from working. So if you're going to stop the plasmin from working, your clot's going to be protected. Okay, so the anti-plasmin alpha-2 plasmin inhibitor will protect the clot. If it's bound to fibrin, then the fibrin is going to be dissolved. Okay, so you have a complex. So it has found plasmin that has not been bound to fibrin. Okay, so the inhibitor, the alpha-2 plasmin inhibitor complex is now bound to free plasmin, because if plasmin is bound to fibrin, then the fibrin clot will dissolve. But if the alpha-2 plasmin inhibitor complex it's thought to be the activator of the fibrinolytic system. Okay, so what that means is you got free plasmin. You got free plasmin, and it's inhibited by the alpha-2 plasmin inhibitor. So the plasmin alpha-2 plasmin inhibitor complex is thought to be the activator of the fibrinolytic system. Okay, well, let me continue further. So plasmin is now bound to fibrin. Because plasmin is bound to fibrin, the alpha-2 plasmin inhibitor cannot bind to plasmin because the plasmin is already occupied. It's bound to fibrin, resulting in clot lysis to proceed. Okay, so if it's free plasmin, then the plasmin will not and it's bound to the anti-plasmin inhibitor, then you will not get clot lysis. That sounds like it's the opposite, isn't it? Alpha-2 plasmin, okay, so if plasmin is bound to fibrin, then clot lysis will take place. You see that?
Yes.
Okay, so if plasmin is bound to fibrin, clot lysis will take place. Clot lysis will not take place if the inhibitor will bind to plasmin. Okay, do you see that?
Okay, that makes a lot more sense.
Yeah, okay. Why don't we leave it at that? Because the inhibitor, if the inhibitor inhibits plasmin, then the clot will be protected. You see that? The inhibitor, if it binds to the enzyme, then the clot will not be dissolved by the plasma because it's going to inhibit plasmin. You see that? If you have the job of plasmin is to dissolve a clot. If you inhibit that plasmin, then the clot will be protected. It will remain intact. Okay, it's kind of backwards because it's a plasmin inhibitor. What the plasmin does, it's going to dissolve a clot. But if you have something that's going to inhibit it, then the clot's going to remain. It's going to remain and not be dissolved. You have to read this about 2 or 3 times, and I had to. Each time I read it, it's like if it's bound to fibrin, the fibrin is already a done deal. The fibrin is going to dissolve. Okay, but the inhibitor will act on plasmin only if it's free. Okay, so if the plasmin is already attached to fibrin, then it's already a done deal. That fibrin is going to dissolve. You see that?
Yes.
Okay, let's move on before we go backwards. Okay, fibrinolysis. Okay, you have two types of fibrinolysis, primary and secondary. Okay, primary fibrinolysis is a normal body process where, like what I just went through. It's a normal process of dissolving clots that have formed. And secondary fibrinolysis is the breakdown of clots due to another reason, like a drug or a medical disorder or some other cause. So that's secondary fibrinolysis. It's like an external cause of dissolving clots. But you have fibrinolysis, that's your normal body process, response to excess clots forming in your body due to an injury, for example, and your body is responding to the clots formed, the fibrin formed when you do have an injury. That's primary fibrinolysis. So secondary fibrinolysis is due to a clot or medical disorder or some other cause. Okay, DVT, I talked about DVT last time too. So a person has varicose veins, right? These large veins here, they're engorged. So you have normal blood flow here like this. But in deep vein thrombosis, what will happen is the platelets will accumulate. Okay, that's why thrombosis, it's the platelets that are doing this. So the platelets will accumulate and cause the veins to enlarge. So, and it'll enlarge to the point where DVT is a really bad medical situation, because if a part of this platelet plug here that's forming, accumulation here in your vein, breaks off, if this portion here that breaks off from the large mass here, it's called an embolus. And if it goes to your lung, then that's where you get a pulmonary embolism. If it goes to your brain, you can imagine what can happen. You can probably get a stroke or something, right? So this is what happens in deep vein thrombosis. You get the accumulation of platelets to the point where it will get large enough, and an embolus will break off and can cause pulmonary embolism. So blood flow to the heart goes here, venous clot is here, and what will happen is if there's a clot here, then the blood flow here in this direction will be slowed down. If that happens, you're going to get fluid accumulation in the lower part of your leg, swelling and inflammation below the blockage site. That's why a lot of times it's good to wear those compression socks, or after surgery, they do compression on your legs. They have these automatic squeezers of your legs to keep the flow going, because you don't want to, if you're being in the bed for a long time, you need to have good blood flow towards your heart. And the compression socks and these leg squeezers, it's automatic, they'll help keep your blood flow so you don't get accumulation of the platelets. Oops. Okay, fibrin degradation products, I talked about that, how they're formed are substances that remain in circulation after your blood dissolves a clot. And remember, it's the macrophages that do cleanup on some of these fibrin degradation products. So when a clot and fibrin net dissolved fragments of protein are released into the circulation, and like I said, macrophages will take care of those. Reptilase. Reptilase time is basically, they don't use this test anymore, and I'll consider taking it out of the lecture next year. But the reptilase time is a blood test used to detect deficiency or abnormalities in fibrinogen, especially in the cases of heparin contamination. So it was one of the ways that the laboratory could detect whether or not a specimen was contaminated with heparin. Okay, because what's the rule? You never draw blood above an IV, correct? Because the IV has heparin, and all of a sudden, the patient has an extended or prolonged PTT. And so when you report that prolonged PTT, the nurses can say, why is it prolonged? The patient's not on heparin. And that's patients in the ICU are usually on a heparin drip, or they have a heparin line. Well, if you draw above that heparin line, then you're contaminating your blood with heparin, and heparin will cause your PTT times to be prolonged. So the reptilase time, if it's not if it's not prolonged, and this is how they tell, if the reptilase time, it's a test, if it's not prolonged in samples containing heparin. So if it's normal, that's bad. It's bad news. If it's prolonged, then that's good. On the other hand, then you can do another test for heparin contamination, and that's the thrombin time. If the thrombin time is prolonged, then you have heparin contamination. So thrombin time prolonged is heparin contamination. Reptilase time prolonged, not prolonged, is heparin contamination. So normal reptilase is heparin contamination. Abnormal thrombin time is heparin contamination. And reptilase, what it is, it's an enzyme found in the venom of the Bothrops snakes, the Bothrops snakes, and has activity similar to thrombin. So when somebody's bitten by a snake with hemotoxin venom, what happens is that the venom acts to lower blood pressure and encourages blood clotting. Okay, and the two basic types of venom toxicity are hemotoxicity and neurotoxicity. Two types of venom are hemotoxicity and neurotoxicity. And that's it for fibrinolysis. So again, make sure you memorize, make sure you know that for sure. That's not too bad, but this fibrinolytic pathway. Know the activators. Activators are in blue. Activated, and this is urokinase, streptokinase, and these factors here, 11A, 12A, and kallikrein. These are the activators. This will let fibrinolysis take place to dissolve the fibrin. And then the red will keep the fibrin intact. These are the fibrinolysis inhibitors. So your two inhibitors, three inhibitors are the Plasminogen Activator inhibitor, will stop the activator, and these two, remember, the two alphas are inhibitors. They will inhibit plasmin. Antiplasmin is fast and macroglobulin is slow. All right. I'm going to be sending you a review of this, and then at the end of my review for the coagulation cascade, there's some things I'll show you that I want you to memorize. Okay, so that's it for fibrinolysis. Are there any questions?
Yeah, can you go over the circulatory changes during fibrinolysis?
The circulatory changes?
Mm-hmm.
For example, okay, so like for example, when you get a cut.
Yeah.
Okay, so what happens is when you get a cut, when you get an injury, you know, what happens is the coagulation cascade, the platelets will form. Remember, it's white first and red, then red. So the platelets will form, and then the platelets alone won't keep the blood from flowing. There's going to be constriction of your blood vessels. That's your body's doing that, okay? Your body's going to constrict the blood vessels because you want to limit blood flowing out of your body. So there's going to be blood constriction, blood vessel constriction. Okay, so you form your platelet plug, and then next thing what will happen is the platelets are there for us to form the platelet plug, and then the activated coagulation proteins in the coagulation cascade. You remember those, right? But I'm going to go over the coagulation cascade later. So the activated factors in the coagulation cascade will also arrive at the site of injury. So what they will do is the cascade will form fibrin. So what will be created will be a fibrin meshwork, and that meshwork that's formed, it's kind of like a net. It'll go over the platelet plug and secure the platelets on the site of injury. Okay, so you got your coagulation factors arriving at the site of injury. The coagulation factors will go into the coagulation cascade, and remember, the end product of the coagulation cascade is fibrin. Okay, so this fibrin that's being created with all the activated factors arriving at the site of injury, plus the platelet plug, will stop you from bleeding, and that's what actually forms the scab. Okay, so is that clear? Is that what you meant by what happens in the circulatory?
Yes, that clears things up. Thank you.
Okay, so now that when you get a cut and you're bleeding all over the place, and I know you've had when you were little, when you were 2 or 3, and you cut yourself and you formed a scab, and you thought, wow, that's pretty cool, you know, and you're gonna pick away at that scab. Well, that scab is the platelet plug with fibrin on top of it, and it hardens, and it's gonna, that's what that is. If you're ever wondering, you can tell that to your kids and they'll be impressed. Any other questions? Okay, so I'm going to